Hello, thanks for joining. I'd like to talk about the second congenital heart disease, SDL, and this one concerns right to left shunts as well as obstructive defects. And both of these present very differently than left to right shunts, which would be considered the most benign out of all these cardiac defects. The right to left shunts are also known as the cyanotic shunts because they involve the mixing of blood from the pulmonary circuit, the right side of the heart, with the left side of the heart that goes out to the rest of your body. Whenever this happens, you deliver deoxygenated blood to the tissues, and it's deoxygenated because it bypasses the lungs. The most common right to left shunt is the Tetralogy of Fallot, and it's anatomically complicated. There are 4 different defects involved in the overall picture of tetralogy. In order, they are a infundibular pulmonary stenosis, a ventricular septal defect, a dextroposition of the aorta, and a right ventricular hypertrophy. Now, when they say dextroposition of the aorta in this particular text, I don't think that's a very accurate terminology. I think that an overriding aorta is the best way to describe it because it's not particularly inverted, and the pulmonary artery is still where it should be attached to the right ventricle. So I wouldn't really call it dextroposed, knowing that that means flipped from right to left. I would call it an overriding aorta. And because there are 4 criteria, this is an easy question to ask where they describe the clinical vignette of a tetralogy patient, and then they say, well, what would you not expect to see in this patient? And they just want to make sure you know all 4 components of the Tetralogy of Fallot. To understand what's going on in the big picture, you want to think about the flow of blood through the heart in a tetralogy patient. And I've illustrated that as best as I can here on this graphic. The red margins represent the pulmonary infundibulum. And the infundibulum is the top part of the interior of the right ventricle. So when there is a stenosis of the pulmonary infundibulum, that means that there is a narrowing or an obstruction of sorts right before flow gets to the pulmonary valve. So it's not necessarily a problem with the valve, it's a problem with the infundibulum. And the plane of stenosis I've tried to represent with this yellow line here in the image. As you can tell, the aperture of the interior of the ventricle is very narrow at that point. So it's tough for blood to get through there. And as a result, the trunk of the pulmonary artery is hypoplastic because it's not receiving enough blood to force it open all the way, right? So thinking about where blood is going to go after it enters the right atrium from the system, it's going to proceed into the right ventricle as normal. And then the right ventricle is going to kick it up and try to force it through this stenotic infundibulum into the pulmonary artery. But because it's narrow, that doesn't happen very often. So instead, the blood gets kicked over to the aorta because of the ventricular septal defect. And that deoxygenated blood combines with oxygenated blood that did happen to make it through the lungs, and it goes out the aorta, and it's got a severely reduced oxygen saturation compared to a normal person's blood. So this accounts for the cyanosis. Whenever that purple blood makes it out to the periphery, it doesn't have any oxygen on its hemoglobin to be able to deliver to tissues. So even though they are perfused, they are still hypoxic, those tissues. That's the gist of the main symptom that you'll see in tetralogy, which is the cyanosis. Anatomically, these 4 symptoms together start with a defect in the Truncus Arteriosus. So it's called a conotruncal defect. And we'll talk more about that anatomical landmark a little bit later in this SDL. What you ought to be able to recognize is that pulmonary stenosis in these patients is due to the underdevelopment of the pulmonary infundibulum. And one more time, the infundibulum is this area outlined in red at the apex of the right ventricle, and it should be wide but in a tetralogy of Fallot patient, it's skinny, and so you can't fit blood there into the lungs, so it has to go through the ventricular septal defect instead. And the degree of stenosis, or the width of this yellow line right here, is going to determine the amount of blood that the right ventricle can pump into the pulmonary circuit. And that is going to determine the degree of cyanosis experienced by the patient and the degree of all of their symptoms in general. It's all downstream from the width of the infundibulum. And this comes up at the top of page 3, where the text mentions that the degree of cyanosis experienced by the patient reflects the severity of the outflow tract obstruction. And I think that's particularly question-worthy because that's kind of the root cause of all of the symptoms you start to see in a tetralogy of Fallot patient. That is, the degree of infundibular stenosis is going to determine the severity of the symptoms that you see in these patients. Moving on to the clinical presentation of tetralogy of Fallot, we know that cyanosis is very common, and we know that it's common at a young age too. It's common because blood is bypassing the pulmonary circuit and it doesn't have the chance to be oxygenated. It's passing through that ventricular septal defect and exiting through the aorta after it fails to fit through the stenosed pulmonary infundibulum. A tetralogy, however, may not present with cyanosis. This will occur in cases of tetralogy of Fallot in which the degree of stenosis is mild. In other words, it's relatively easy to still fit blood through the pulmonary artery into the lungs. When the patient doesn't have much of a problem pumping blood into the pulmonary circuit, we call that a pink tetralogy because they will have the gradual heart failure characterized by the tetralogy without the cyanosis because they're still able to pass blood into their lungs and thus oxygenate it. Now, there are a couple of pathognomonic signs that you will see in tetralogy, which is handy for us clinicians because it means that diagnosis is really not that much of a challenge. Patients will usually present as very early infants with fainting spells. They may or may not be blue, but they'll usually have these TET spells. And you ought to know what a TET spell is and be able to recognize it not just in a stim, but in real life. Patients will become cyanotic, so blue, basically. Hyperpneic, which means that they'll be breathing rapidly and shallowly too, and lethargic, so they might just pass out of nowhere. TET spells are particularly important to catch quickly and recognize right off the bat because they might result in death if they're uncorrected. Squatting is another particular symptom associated with the tetralogy, and the mechanism behind it is a decreased venous return to the heart, causing it to not have to work as hard and allowing more blood proportionately to fit into the lungs per stroke of the right ventricle. It's not particularly important, I believe, to know how this mechanism works because it is such a peculiar finding that, again, when you see it, you will know that it is the tetralogy of Fallot because just about nothing else is going to have squatting to relieve this stress. Another distinctive symptom of the tetralogy and a symptom that you may see in any right to left shunt is clubbing of the fingers or toes. And clubbing of the digits is indicative of a severe hypoxia in that region of the body. And the reason I say in any right to left shunt is because this could be a presentation of Eisenmenger Syndrome, which is the reversal of a left to right shunt into a right to left shunt. So anytime you get a right to left shunt, you're bypassing the pulmonary circuit. And that's worse than a left to right shunt because with a left to right shunt, you're putting more volume in the pulmonary circuit and it just gets stuck there. So you're a little bit hypoxic to the rest of your body, but you're still delivering oxygen to your tissues. With a right to left shunt, you're missing the lungs entirely, and lots of blue blood is not even getting the chance to go to the lungs. And when that blue blood accumulates in the distal extremities, it doesn't deliver any oxygen to them, and it spurs a biochemical reactive process that causes this clubbing, most likely through VEGF proliferation, but we still don't know the entirety of the factors involved in this situation. So on a chest radiograph of a tetralogy patient, you will see a boot-shaped heart, and that is pathognomonic. It's fairly L-shaped. You see a right ventricular hypertrophy along with a hypoplasia of the main pulmonary artery. And right along here, it should be radiopaque because there should be a pulmonary artery right there going to the lung, specifically the left lung. But because it's really skinny, it's not showing up very well on this radiograph. And so the superior-most border of the heart, or the left heart lateral border, is even more pronounced than normal because you see more of it because you're not seeing the pulmonary artery that should be there. Finally, there are some complications of tetralogy of Fallot that you should be aware of because, as we know, complications are very highly tested. Specifically, the complications include polycythemia, paradoxical embolus, pulmonary embolus, and infective endocarditis. And I want to start by saying that infective endocarditis is not particularly particular to the tetralogy of Fallot. Any congenital heart defect will predispose that patient to an infective endocarditis. However, there is a particular infection which is fairly specific to the tetralogy of Fallot and to right to left shunts in general, and that's the brain abscess. As we know, there is a gray-white junction of the brain, which receives lots of blood. So whenever the oxygen content of the blood delivered to the brain is severely decreased, this area gets very hypoxic. And when that happens, there's potential for bacterial growth, particularly from anaerobic organisms too. So brain abscesses are going to present usually as singular lesions, possibly multifocal. They're particularly threatening, and you need to be able to diagnose it right away whenever you recognize a high fever, basically a discontent baby, you know. Polycythemia is another key consequence of the tetralogy of Fallot. What happens in polycythemia means many cells in the blood, is that you start to upregulate your erythrocyte production in an attempt to compensate for the systemic hypoxia mediated by these oxygen-less red blood cells that get delivered to your tissues. So over time, you'll make more and more blood cells, and your blood will become more and more viscous, and this could increase the risk of clotting and thrombotic event. And that increased risk of clotting is seen by the increased risk of stroke, which is also mentioned in this paragraph. The polycythemia leads to more viscous blood, and clotting is initiated by clotting factors binding to one another, and anything that increases the viscosity of the blood also increases the probability or likelihood that these clotting factor proteins in the blood randomly run into each other and start the clotting cascade. That's a simple explanation of it. So that's the tetralogy. Moving on to Eisenmenger syndrome. Eisenmenger syndrome is basically a shunt reversal. And it's not an inherent pathology, meaning you're not born with Eisenmenger. You develop Eisenmenger. And it always happens like that. I'm not going to spend too much time on Eisenmenger in this text because I believe that the text goes into excessive detail regarding what you ought to be aware of in Eisenmenger. You should mostly recognize it, but because it's never the underlying pathology, it's always a consequence of some other underlying pathology, there's not too much that you can actually ask about Eisenmenger. As we see in this little box here, it is a continuum or a progression of histopathologic changes. It is not any one thing that is going to immediately lead to the development of Eisenmenger syndrome. It's this gradual process of shunt reversal that happens as the right side of the heart hypertrophies. And as it does, it puts more volume into the pulmonary circuit, and the pulmonary circuit just can't take that volume. So the high hydrostatic pressure within the lungs is going to cause a fluid edema to build up in the lungs, and you're going to get this pulmonary vascular obstructive disease as a result of the high hydrostatic pressure mediated by that high blood flow. And when you get this pulmonary obstructive disease, you're going to see a backup of fluids behind the lungs, because that's what happens whenever you put a rock slide into a river. The water backs up behind it, right? So this results in pulmonary hypertension, leading to right-sided heart failure, because that right side of the heart has to pump harder and harder and harder to get blood into that increasingly hypertensive pulmonary circuit. So as it does that, it eventually reaches the point where its pressures are higher than the left side of your heart, because they have to be high in order to force blood into those stenotic arteries. And when that occurs, the moment that that right heart pressure is higher than the left heart, you've got Eisenmengers. And you've got a reversal in the flow of that shunt. It's no longer left to right, it becomes right to left. That's Eisenmengers. This table is fairly excessive. I'm not going to memorize it. I'm going to be able to take a good guess. You know, I mean, if you get a question, obviously it will either be a stage 1-2 type thing, or it will be a stage 5-6 type thing, or it will be somewhere in the middle. Use your best judgment on it, but this is one of the things that I would pay attention to last in my order of operations through an SDL. And then you get some pathology slides, and basically there's not much going on here. It's just showing you a normal lung here on the left, and then it's showing you an extremely fibrotic and stenosed pulmonary artery here on the right. And you can tell that it is an arterial and not a capillary bed due to the original thickness of this cell wall. It has both an internal and an external elastic lamina, and capillaries don't have that. They're a little bit more tinier than that. So we know we're looking at an arterial, and what we're looking at on the interior of this lumen is a hyperplasia, not a hypertrophy. That's when cells get bigger, but this is a hyperplasia, meaning a multiplicity of the number of endothelial cells within this lumen. This immediately tells us that that endothelium is under stress. And the reason that that endothelium is under stress is because of the high hydrostatic pressure passing through it on a continual basis. You keep that high pressure up, it's a stress. And what do endothelial cells do in response to stress? The same thing that all cells do. They swell up and they divide. So in this case, they're dividing. Moving on, we're looking at a little bit farther down the line consequence of pulmonary vascular obstructive disease. And again, this is when fluid escapes out of the vessel into the endothelium. As you can see with all of these wide kind of full capillary channels in this photo, the fluid's leaking out into the alveoli, causing a widening of the spaces in between these alveoli. They should be a lot closer together. In the top right, we're looking at necrotizing arteritis, and I've got my SDL in black and white because I find it easier to see my own highlights. It's less distracting to me, but if you were looking at the color version, you would see that this ring around the endothelial lumen is a bright, bright pink. And that very bright pink, or eosinophilic, is characteristic of fibrinoid necrosis. So if you're looking at a small artery and it's got a big, bright pink ring around it, and it's anuclear, meaning you're looking for the nuclei of individual cells, but you don't see very many nuclei in that ring, then you're probably looking at a fibrinoid necrosis. On the bottom left, we see more hyperplasia, and we even see a hyperplasia of the tunica media in between the two elastic lamina here. And then finally on the bottom right, we see a thrombus, which is this red material occluding the interior of the lumen of this artery. So going on to the clinical presentation, Eisenmenger syndrome is nearly equivalent with cyanosis, or at the very least, you won't be able to tell if it's Eisenmenger or not until the patient does present with cyanosis and or digital clubbing. So those are the two signs to keep an eye out for with Eisenmenger. Let's move on to the Truncus Arteriosus. This is an anatomical structure that is the origin point of both your aorta and your pulmonary arteries. And it's going to split in two in order to form both structures, and it should separate entirely. If it does not separate entirely, then you still have one trunk when you're born, and that's a bad thing. You want to have two separate vessels here. So because of this incomplete separation, you're going to get a chest radiograph that's very, very wide at the aorticopulmonary trunk. I would say that that's the most common means of testing this, is simply a gross pathology question where she may show you an X-ray or show you a gross dissection of the heart and just ask you multiple choice, what is this, you know, because due to the complex anatomical nature of all of these malformations, they're moderately hard, you know, and you can't always differentiate one from the other. So expect to see lots of gross pathology questions on this upcoming exam. Besides that, I didn't really pick up anything out of the norm about Truncus arteriosus that you wouldn't expect to see in any right to left shunt. You know, you're going to see some degree of cyanosis. You're going to see some decreased systemic O2 sat. You're going to see a right-sided congestive heart failure as you have to pump blood into those stenosed lungs. And you're going to see recurrent respiratory infections as a consequence of the fluid that builds up in the lungs. All of these are indicative of a right to left shunt in general and not necessarily specific to the Truncus arteriosus, which is what makes me say that any question you get involving a Truncus arteriosus will be simply an identify this type of question. Let's look now at the total anomalous pulmonary venous return. And this is kind of the older brother of the partial anomalous pulmonary venous return that is a left to right shunt that I covered in the last SDL video. A total anomalous pulmonary venous return is the drainage of all four pulmonary veins into the systemic veins of the right atrium. And when this happens, you really don't have anything going back to the left atrium, you know. All of the oxygenated blood from your lungs is going back into the superior vena cava. So that means that you have to have an atrial septal defect in order to even work, in order to even live, you know, because otherwise no blood at all is getting into your left heart. And that's what this image on the left represents, is the atrial septal defect you can expect to see in a total anomalous pulmonary venous return. So it could be an atrial septal defect. It could also be a patent foramen ovale. Remember that a patent foramen ovale is not technically an atrial septal defect. Once more, there is not a lot to talk about with this particular malformation. It's going to be a diagnosis of, do you know what this is, you know, with a gross image or a radiograph to have to pick apart. Now let's talk about transposition of the great arteries. This is what happens when everything about your heart is normal, but the aorta attaches to the right ventricle and the pulmonary artery attaches to the left ventricle. And it doesn't really look like anything else besides dextrocardia. And there's probably going to be a question on any exam about, well, what is this, you know? And they'll show you a gross picture of the heart, and it's going to be all out of whack. And you're going to have to make the diagnosis. Is this a dextrocardia, which would mean the heart is tilted off to the right? Is this a transposition, which means that the two great vessels are switched, but the heart is tilted to the left? The only other thing I see about the transposition of the great arteries is that you basically have to have an interatrial communication with this condition as well for it to be compatible with life. Almost all patients have a patent foramen ovale, 2/3 have a patent ductus arteriosus, and 1/3 have a ventricular septal defect. And again, these are facilitating the channeling of blood between the right and the left sides of the heart, because we go up here and we look and we see that if you don't have any holes in your heart, then there's not going to be any way for blood to get through to the rest of your systemic circuit from the lungs. Looking at the tricuspid atresia, this is basically whenever the tricuspid valve fails to form, you just have a flat tissue, you know, and where you should have a valve, you just have a door basically that won't open. It's flat, it's a wall, no blood's getting through it. It's basically the same thing as a muscular wall, except it's very thin. So the valve is absent. What happens? Well, blood enters the right atrium from the venous circulation, the systemic circulation, and it goes through a patent foramen ovale. And so then you've got purple blood in your left atrium that you're putting back into your left ventricle, and the left ventricle is having to pump blood into both the aorta and the pulmonary circulation. So this is compatible with life, but it's certainly not desirable. What you want to know is that these patients will present with cyanosis as well as with any right to left shunt because blood is bypassing the lungs and going straight to the systemic circuit without being reoxygenated. The prognosis is very poor. So let's talk about Ebstein anomaly now, which is another anomaly involving the right atria. This is a right to left shunt. What's going on with Ebstein anomaly is atrialization of the right ventricle. That's it in one statement. And if you can understand what that is, you'll understand Ebstein's anomaly. And what that means is that the atrialized right ventricle contracts during systole, right? But the problem is, whenever this atrialized right ventricle contracts, it forces some more blood through the tricuspid valve. And the tricuspid should be closed at the start of systole, right? So whenever the atrialized right ventricle pushes blood through that tricuspid, you've got a little bit of a leak. This is going to cause a backwards flow of blood or a regurgitation of sorts into the right atrium. And that's the right to left shunt. So Ebstein's anomaly is not a shunt in the traditional sense, but it is a shunt in the sense that you have a compromised tricuspid valve that allows for the spillage of volume of blood back through from the ventricle to the atrium on the right side. That's your right to left shunt in Ebstein anomaly. There is a particular heart sound associated with Ebstein. It's called the sail sound. It's a widely split S1 with a loud tricuspid component. I would be able to recognize that because it may help you make a diagnosis. In terms of what sort of exam question you could expect from this, I would think that it would just be either a what is this, identify it if you were given a picture of Ebstein's anomaly, or it could be a general pathophysiology question about right to left shunting in general, and you would have to know things like cyanosis is what you would expect downstream as a chronic result of this shunt, or something like the pulmonary artery is going to become stenotic and hyperplastic as a result of getting all that extra blood force through it. So moving on to the obstructive malformations. The first one we're looking at is a congenital aortic stenosis. And a stenosis is a narrowing of a flow channel. So knowing that, the height or level of the stenosis can be underneath the valve, on top of the valve, or at the level of the valve. And so that's called a supravalvular, valvular, or subvalvular congenital aortic stenosis. A bicuspid aortic valve will predispose you to aortic stenosis. So I know that that was mentioned at the head of last SDL, but the text didn't really talk about what you see in a patient with a stenotic bicuspid aorta. What you're going to see is around the age of 40 to 50, they're going to have a left heart hypertrophy as a result of this increased afterload. So their left heart's going to have to work harder, so they would have all of the symptoms traditionally associated with left heart failure, and they would have a very loud clicking sound where you would auscultate their aortic valve. There's an association with Williams syndrome, and that's the only thing in the text that is particularly memorable that doesn't make sense if you just think about it for 10 seconds, Moving on to the coarctation of the aorta. This is a cool pathology. And I would say that the coarctation is a little bit more high yield than almost everything else in this SDL besides tetralogy, because coarctation has a bimodal presentation. You either catch it in infancy or you catch it way later in life. And the age at which this pathology presents is dependent upon where the coarctation is. Before we go any farther, there's a slight association with males, 2 to 5 times more common. Well, I guess that's moderate, So if it's what's the predisposing factor, the answer is male gender. Because you're born with it, it's not going to be smoking or obesity or anything. So we are talking about locations of coarctation. And a coarctation is going to occur before or after the ductus arteriosus. Now, We know that the ductus arteriosus is going to close, right? And it's going to close because of prostaglandin E2, and it's going to fibrose, and that means you're going to have a patent aorta and a patent pulmonary artery. Well, when it closes, you may or may not see the presentation of a coarctation. A preductal coarctation is right here, and as you can tell, it's immediately before where the ductus arteriosus closes. So let's say you have an infant, right? And they're born and they seem reasonably healthy. And then all of a sudden their ductus arteriosus closes. Well, if they have a preductal coarctation, all of a sudden you can't push blood past that. You can't push blood past it, right? So the infant's just immediately going to get cyanotic in the lower extremities. And it's going to be only the lower extremities usually, because the blood has already been able to pass through the brachiocephalic artery and the subclavian artery on the left side to get to the upper extremities. So their bottom half is going to turn blue. And that's very particular to the coarctation of the aorta, is a differential cyanosis. All these other right to lefts, you get a full body cyanosis, but this is not a right to left. This is an obstructive defect. You'll see a differential cyanosis with it. So that's what happens if you have a preductal coarctation. It'll present in childhood. Now, what if you have a postductal coarctation? Well, you're just going to continue as usual, and you won't see any acute presentation of symptoms, because it's not like anything's really changed when that ductus closes, you know. This coarctation can get worse and worse and worse gradually, because it's imposing a high afterload on the left ventricle, and eventually the left ventricle will not be able to push blood through that coarctation, and so you will see the presentation of a coarctation in an adult when their left heart fails. There are some particular symptoms that are common to both children and adults. One of them is rib notching. Another is a differential blood pressure between the upper and lower body. And as we mentioned, that's because, look at where the coarctation or the stenosis is. It's downstream from the upper extremity feeding arteries. You are already sending blood to your upper extremities, and then there's a coarctation. So your pulse and your brachial pulse is going to be fine. It's your popliteal pulse that's going to be very, very absent, you know. Also associated with the coarctation is the bicuspid aortic valve, as well as Turner syndrome, which is 45X. So now we get into differential presentation between neonate and adult. Neonates are characterized by sudden acute left ventricular failure whenever that ductus closes. Again, you see a severe hypoperfusion of the lower body. It can lead to kidney failure. And a cardiomegaly is seen on X-ray. Why? Because of that high afterload, the entire heart's volume overloaded. It can also present a little bit past the neonate period in infancy or early childhood. This sort of coarctation is asymptomatic for a while and may initially present as a differential systolic blood pressure. Adults who get a coarctation are usually caught by the doctor whenever they present with a heart murmur. And they'll be, you know, in their 30s, 40s, 50s, and the doc will say, have you ever been told that you have a heart murmur? And they'll say, well, no, this is the first time anyone's ever told me that. So you being the doctor say, systolic murmur, systolic murmur. Well, let me check their pulse, right? Well, then let me check their lower extremity pulse. So you do both of those, and then you realize, oh man, this guy is thumping at his wrist, but he's quiescent down at his ankle. You know, you take his dorsalis pedis and it's just like, it's not there. So that's the clinical presentation of an adult coarctation. Some more pathognomonic signs include the figure 3 configuration on radiograph, which if you kind of look at the outline of this aorta, it kind of looks like a 3. So that's fairly pathognomonic. Shoot, that is pathognomonic. What else is going to make your aorta look like a 3? Maybe syphilis, I don't know. Furthermore, there's rib notching. And there's rib notching because your internal thoracic arteries have to get blood to your lower extremities when there's this coarctation, right? So you've got to get blood down to your lower extremities somehow, and there's an obstruction here in the middle of the aorta. How do you do it? Well, you pop blood up your brachiocephalic and up your subclavian, and then it goes down your internal thoracics, and then it goes out your intercostal arteries, right? And that's how you perfuse the walls of your abdominal cavity. And that's how you perfuse a lot of your viscera. And that's how you send blood down to your iliac arteries, is your internal thoracics will grow collaterally and communicate with the iliacs in the event of the aortic stenosis. So that's the concept of collateral blood flow. Again, in neonates, you're seeing a preductal stenosis. In adults, you're seeing a postductal stenosis. Rib notching is pathognomonic. The large pulse differential is fairly diagnostic. The patient may present with a compensatory hypertension because whenever you've got systemically low blood volume, you don't really have a low blood volume. It's just you have this obstruction, so you're not delivering enough blood to your lower extremities and particularly to your abdominal viscera. So your body interprets that as you not having enough volume, period. So it responds as if you need to raise blood volume. So you get your renin, angiotensin, aldosterone system kicking, and they all chip in, and you retain sodium, and then you present to the doctor with a blood pressure of 170 over 100 because you've been hypovolemic for a few decades now, right? So that's what that is. The final part of this SDL is cardiac malformations causing no shunt and no obstruction. And this is where we get into dextrocardia. And I believe that the exam question here is going to be just a very simple, you get a picture of pathology and it's ABCD. Dextrocardia, transposition of the great vessels, situs solidus, situs inversus, and then maybe situs ambiguous, and you just have to be able to discern which of these flip-flop hearts it actually is. Make the diagnosis on a flip-flopped heart. So read through this section. Know that dextrocardia means that the heart is located in the right thorax instead of the left. Know that situs solidus means that all of your organs are in their normal place. And then situs inversus means that all of your organs are mirrored. They're flip-flopped. Finally, know that situs ambiguous is a disturbance in the usual left and right distribution, meaning some are going to be where they should be, some are not going to be where they should be. So it's not an all or nothing type thing as the situs inversus and situs solidus is. And finally, the reason why I say this is probably going to be a visual diagnostic question is because it says dextrocardia is usually detected by chest x-ray. And that's about all that it gets us about dextrocardia. It doesn't really talk about the pathophysiology behind it. So expect an identification question. And finally, there is the anomalous origin of the coronary artery from the pulmonary trunk. ALCAPA is the anomalous left coronary artery arising from the pulmonary artery, and ARCAPA is an anomalous right coronary artery. And as you can imagine, the left and the right coronary arteries supply vastly different distributions of the heart, and so they're going to lead to some quite different symptoms. Specifically, the ALCAPA is going to lead to a left ventricular ischemia, and the left coronary artery also supplies the anterior septum, which is where most of your conduction bundles are. So ALCAPA as a whole is going to have much more serious consequences than ARCAPA. ARCAPA is going to be a more drawn out, slower presentation because your right coronary artery does not supply the septum. So the conduction of an action potential through the heart is not dependent on your right coronary artery, right? So whenever you have ARCAPA, it's going to be more drawn out because you can live with it for a longer time. ARCAPA presents with this coronary steal phenomenon by which the pressure inside the right coronary artery is so low that blood diffuses through the tissue of the heart into the coronary artery, and the right coronary artery becomes as a vein and delivers that blood back to the pulmonary artery. And that's it. Any question on this? Maybe I could see a diagnostic question being presented with this. It's a hard diagnosis to make unless you get a heart cath or a specific study. You know, I suppose that you would expect to see a little bit increased oxygen saturation within the pulmonary artery, but that might be it, really. And that's all that I have for this SDL. I tried to do as good a job as I could of explaining some of these things that are fairly new to me. So thank you for sticking with it. Thank you for watching.